Live, sir. Please start.
On behalf of ARIS, welcome you all to this Crevast Academy, to this seventh session of Crevast Academy. At ARIS, we practice strong value system. We practice power of empathy, truth of science. When we practice these value system, it helps us to really strengthen our clinicians in improving healthcare outcomes of our patients. And the various patient care initiatives we have highlighted here in our slide, which actually has made ARIS a number one company in patient care initiatives. This is the seventh session of Crevast Academy, which runs round the year, where we present a curated content to disseminate and master the nuances in clinical management for improving CV outcomes, thereby guiding clinicians across India to improve CV healthcare in patients. The first session we had on 8th April, where we had eminent panelists from across the country who participated in this, along with many delegates who logged in online. The second session we had on 13th May 2023, continuing with session 3 on 10th June 2023. And then we had next session on 8th July 2023 that shows our commitment to Crevast Academy. And the last session we had on 23rd September 2023, that was session 6. And today we have 7th session, and we will have discussion on intensity matters, deciphering its significance in statin therapy. We have with us Dr. Sanjeev Shah, who is an endocrinologist attached to Nanavati Max Super Specialty Hospital, Mumbai, who is an academic clinician working in private practice and who has an experience of more than 40 years. Dr. Sanjeev Shah was attached to KEM Hospital in clinical pharmacology for around 5 years, and he has been the researcher in global trials in diabetes for more than 20 years. Dr. Sanjeev Shah has around 50 original research papers and 20 book chapters to his credit. So that's the moderator today we have with us, and that is Dr. Sanjeev Shah from Mumbai. I request Dr. Sanjeev Shah to take over the proceedings, and let's make this today's panel discussion a real academic one so that we can disseminate good knowledge to all our Indian clinicians. Over to you, Dr. Sanjeev Shah. Thank you very much.
Thank you, Mr. Gagan. It's my pleasure to be part of this Crevast Academy as a moderator in all the session. We have attempted to have very, very recent papers published on the subject of improving CV outcome with management of dyslipidemia and using statin. And all around lipid science, we were successful so far in discussing the subject with 3 experts with me. So together we are 4 experts. So our subject today is going to be around suboptimal statin use, which is a barrier in management. Right statin dose to counter non-HDL in diabetic patients, and optimal statin strategy to reduce MACE events. So I have 3 experts today. To start with context setting, in our clinical practice, when patient visits for any chronic disorder like hypertension, dyslipidemia, type 2 diabetes, or similar disorders, any vascular disorder, do we calculate CV risk? Over the year, there had been many risk scoring available, originally Framingham risk score, and in recent times, ASCVD risk equation is made very popular. While Indians fit more into joint British society and a modified Q risk scoring. Recently, ARIS has taken certain initiatives so that physicians can use a risk scoring and assign a particular risk, because this is highly relevant in relation to selecting the dose. If you look at this so-called recommendation, patients fit into some kind of a risk, either borderline, intermediate, or a high risk. And based on their risk, physician has to select intensity of statin with a low, moderate, high, or very high intensity. It also depends if there is uncertainty. Calcium scoring is recommended. It has come up in a nice way to predict who will need high intensity statin, who is at very high risk of future CV events. And in the past, one of the meeting, we discussed calcium score quite intensively, and we have touched upon many subjects. So I just show you some of the points that patient is along the journey. And this is something which I show you a paper in relation to a change in the body weight. BMI is changing and patient is developing some risk factor. So this shows you the relationship between increasing BMI in the adulthood and increased risk of cardiovascular disease. I also searched for a vascular aging. Along with I was studying longevity and aging, I came across vascular index and at what age an individual would age in relation to vascular system. And as you can read, about 30 risk factors which have an impact, and there are 9 different models which have been created. This is very recent 2023 April publication in Science, where an individual is constantly aging. Another interesting paper I came across was New Zealand aging study, and they showed right at 38, people were higher and going higher in the age by 5 years. So if people are aging, they are developing subclinical atherosclerotic disease. They have some kind of risk factors. As you can see that apparently healthy is a word, and suddenly a man gets a myocardial infarction or suddenly drops dead. He missed out on the risk assignment. He missed out on lipid evaluation and intensive monitoring. Ahmedabad Aries company is quite aware that there were 17 deaths of Sharma recently during Navratri. Younger people dropping dead. We don't know whether what was lipid, what was myocardial infarction, what was rhythm disorder. But people need, when they visit the physician's clinic for any of these 3 disorders, a risk assignment. And based on the risk, this is 2019 European guidelines on LDL management. A patient may get into a low intensity, moderate intensity, or high intensity statin. This has been discussed and would be discussed in one next 40 minutes. I am surprised the first paper which I am referring to, Dr. Mantri's paper, which is a secondary prevention paper, which is going to come. 20% of the patients were not prescribed statin after hospitalization for acute coronary event. Only 80% received a statin prescription. And going forward, many patients discontinued statin. So who is not sure? Physician is not sure statin to be given or not. Physician is not sure what intensity and what dose and what drug should be selected. Or patient is not sure, so that it is discontinued. When I come to a second talk of today, which Dr. Sharma is going to deliver in diabetic subjects, as a senior endocrinologist in Jaipur, practiced for 40 years like me, We have seen diabetic people progressing simply from hyperglycemia across the spectrum. And now the guidelines have come that right on day one of diagnosis, you look at ASCVD risk factor. And we know that 2/3 of diabetics could have subclinical atherosclerosis. So people progress at different stage. So he is going to touch upon what is relevant in diabetic people. But Dr. Sharma, you will discuss at the end of your talk this particular paper because I would not be able to show the slide in discussion. This is a 2023 guidelines by American Diabetic Association, which has reduced the target LDL from 100 to 70, and in people with high risk, 55. So the risk assignment to diabetic people has changed in recent years, and based on the evidence, we would discuss that point. Diabetic people also have high triglyceride. And I show you a relationship between high triglyceride and cardiovascular risk. As you can see, a patient moves from 100 to 200 and higher. The risk due to triglyceride continues to increase. As you can see on the left bar diagram, 1 in 3 statin treated patients with diabetes had higher triglyceride, while patient with cardiovascular disease, 1 in 4 had higher triglyceride. So triglyceride many times remains unattended, and you know that how triglyceride contributes to non-HDL element, and that's why the evidence suggests that non-HDL might be superior to LDL as a marker of cardiovascular risk. I would request Dr. Sharma, when he talks, will take up this topic. Why non-HDL in diabetic people? Probably it is the sum of LDL and VLDL which reflect the role of small, dense, atherogenic LDL particles, and they are high in diabetic people. So maybe in the future, this may come up as a target in guideline. As this one elegant paper in preventive cardiology showed that non-HDL was better predictor when LDL was flat at 3 millimoles. And the ratio of non-HDL to HDL predicted CV risk much higher. Our last speaker, Dr. Mehta from Pune today, is going to highlight in relation to intensity of statin and relationship with CV events. As you can see, the age going beyond 40, a man, hypertensive, diabetic, smokers, there is kind of a continuous cumulative LDL exposure in life, and a cumulative exposure would result into a risk for CVD. Lower the LDL, better it would be. So today's faculty is going to highlight how to assign a risk to individual and what would be the benefit of statin, particularly high intensity statin. So we are going to have 3 speakers. Nehal or Divyanshu, I think Dr. Mantri has not joined so far.
Yes, sir, correct.
Dr. Mantri has not joined. So
Yeah.
we could take
Move
his
on to next
presentation
session,
at the end.
Yeah.
Dr. Sharma, you are going to, I can continue with your slides? Or your laptop has started?
No, please continue my slides.
You have your laptop and slides?
No, you show the slides. I will speak from here.
Okay, so I will skip Dr. Mantri's. Dr. Sharma.
Yeah.
I received a message that right now on the mobile that Dr. Mantri is busy in angiography for VIP in Gangaram Hospital, typically for Delhi cardiologists.
I think you can take his slides after the, or you can start with his slides if you think.
Sharma ji, I have a statin subject for first speaker and a last speaker. So,
Okay. So I
so
will start.
I would take it a little in brief.
Okay.
So he was to present. See, today we have all the three speakers presenting one case paper, and after his paper, we would discuss with you and Dr. Mehta.
Hmm.
So this is a publication in in the journal Heart in current year. This is a good follow-up in Scotland. With NHS in Scotland, they have a data of a huge number of patients, and they have looked at the statin use and secondary cardio prevention. So to estimate the extent of suboptimal statin use for the secondary prevention of ASCVD, this is a cohort of 167,000 people, 168,000 almost between 2009 to 2017. So it is a retrospective analysis where statin is initiated. Then it is assessed that statin is continued or not. That is an adherence element. If it is not a refilled prescription with a gap of 6 months, it is considered discontinuation. And some of the people have reinitiated the statin. So the behavior of this statin, it was the subject here in 168,000 patients. So individuals being prescribed statin within 90 days of hospital discharge, proportion of the days covered calculated based on the medication dispensed. Adherence is seen that more than 80% of the drug has been taken by an individual. Discontinuation more than 180 days. And reinitiation is considered after 180 days, patient has reinitiated. So it's a very interesting phenomena, whether it's a physician behavior or a doctor behavior. This is the results you can see over a long period of follow-up. 81% initiated statin therapy. How do you see what kind of a statin dose? 40% initiated high-intensity statin, though all the patients were hospitalized and would qualify for secondary prevention and high-intensity statin. But 60% received medium or low-intensity statin. Within 12 months, 43% of statin initiators were using high intensity. So 81%, 40% only continued in high intensity, while remaining percent of the patients continued in moderate or low. Out of all this 80%, 24% users discontinued their treatment at some time point within 1.5 years. So this is funny. And 80% within 3.5 years. So high number of comorbidities were associated with a lower likelihood of individuals initiating statin. Now this is MI and stroke patients with 3 or more comorbidities had 60% and 42% lower odds of initiating statin compared with individuals without comorbidities. The rates of discontinued again varied with kind of a cardiovascular disease. 23% of MI patients, 26% of stroke patients, and 29% of peripheral arterial disease patients discontinued statin. Only 38% reinitiated therapy at some time point after the gap of 180 days. So subsequent discussion, maybe lipid profile or clinical picture resulted into reinitiation. Women had 17% higher hazard of discontinuation compared to men. So physicians perceived that women are at lower risk. If you look at the guideline, 5 years after menopause, women are considered at similar risk, similar to the man. compared with individuals between 60 to 69, those below 50 and those higher than 70 also had higher discontinuation rate. So similar belief in younger people, I call it younger, which is wrong, actually middle-aged less than 50, as well as very elderly people beyond 70, the perceived benefit has been seen to be low. In the past, we have touched upon one paper which looked at age group above 70 and they needed statin as similar to 60-year-old individuals. This is patient characteristics, which is irrespective of different characteristics. Statin is discontinued. This paper concluded that statin use remains suboptimal for the secondary ASCVD prevention, particularly in women and older patients, as well as following ischemic stroke and peripheral arterial disease hospitalization. So MI was seen as more risk compared to other vascular disease. Improving this would offer substantial benefits to population health at a very, very low cost of statin, which is considered as an important therapy. So, Dr. Sharma, this paper is open for discussion with all of us.
Yeah.
Let me check before whether Dr. Ajit Mehta, cardiologist from Pune, who is our third expert today, has joined or not. Otherwise, we could take up discussion after two talk. Divyanshu Nehal, Dr. Mehta has joined.
Yes, sir. He had joined, but I think because of some technical problem, he is left. I think he is joining once again. But till then, we can continue with the discussion, sir.
Dr. Sharma.
Yeah, Dr. Sanjeev, I think this was a very important study and it was done in the West. And if you look into and you compare the same scenario in Indian context, I think we will find that our scenario is even worse because large number of our patients are not prescribed with the statin. If they are prescribed, most of the time the doses are very, very meager. You can see that they are giving low intensity statin therapy and the discontinuation rate is again very high in Indian context. So it is our usual, you can say, scenario that our patients do not realize that continuation of statin will be helpful in long way. And even our physicians are also not stressing this point that high intensity as well as continuation of statin therapy is required. This is my general comment.
Dr. Sharma, I think first and third topic both are in relation to MACE and a statin, but different papers. So we will wait for Dr. Ajit Mehta and take up the discussion after his talk. In the meantime, I would like to welcome our second expert today. Dr. S.K. Sharma is trained in endocrinology way back in Chandigarh and had been a professor of endocrinology and a teacher in endocrinology from Jaipur, currently at MGM Medical College, has already received a lifetime achievement. So Dr. Sharma comes into the category of not senior, very, very senior, those who achieve lifetime award in Rajasthan, but had been part of many awards, many faculties and chairman of many bodies, had been a close colleague and we have shared a teaching platform for last 30 years all over the country. Dr. Sharma is an endocrinologist and not a cardiologist. So his subject today, as I will show you the slides here, is a right statin dose to counter non-HDL. So we are moving little from LDL to non-HDL, and the patients are type 2 diabetic patient. So this is the paper which is published, systematic review and meta-analysis. Dr. Sharma, please.
Thank you, Dr. Sanjeev. It is always a pleasure to be with you and you make the things so straightforward and simple to understand. beautifully highlighted, and I can say you have moderated beautifully. My job is to look at diabetic patients, and in your earlier, you can say, deliberation, you highlighted this point that triglycerides are very commonly seen high in our patients, particularly in our diabetic patient, it is very high. So whenever a patient of diabetes comes with high triglyceride, most of the time we say that it is because of uncontrolled hyperglycemia. And then, of course, we start a good control of hyperglycemia with dual therapy or triple therapy accordingly. And then, of course, we will be continuing with them with moderate intensity or high intensity statin therapy according to their risk profile. And then we again look at, after, let's say, 3 months down the line, if it is still high, as you rightly highlighted, probably we are dealing with patients who are having more of this small, dense LDL particle in the presence of high triglycerides. That LDL cholesterol may not be very high in our diabetic patient, but it is the small, dense LDL particles. And we all know that every particle have a B, ApoB, and ApoB are highly atherogenic, and that's why our diabetic patients are having more risk of developing cardiovascular disease. So this was I should say, a good paper, which is having objective of to compare the efficacy of different statin treatment by their intensity on the level of non-HDL. As we know that most of the time, most of the deliberations are on LDL. But when we talk of diabetic patients, particularly type 2 diabetic patient, we always look at non-HDL, and it is you can say, a better, you can say, give a picture where we can prevent the cardiovascular disease there. So we all know that diabetic dyslipidemia is a commonly manifested as elevated triglyceride, low level of HDL cholesterol, and either normal or slightly elevated LDL levels. But predominantly, because triglycerides are high, so predominantly these LDL particles are small and dense, and they have a high risk of oxidation, and there is a high risk of atherosclerosis there in this presence. So in diabetic patients, non-HDL cholesterol may be a stronger predictor of cardiovascular disease than only LDL cholesterol or triglyceride, because it correlates highly with atherogenic lipoprotein. So non-HDL includes all those particles, lipoprotein particles, which are having ApoB. And once you count all the ApoB, then it is giving a good picture in our diabetic patient. And target goal for LDL and non-HDL is more or less similar. Like LDL, we want less than 100 in our diabetic patient, and non-HDL is a bit 30% higher. But Sanjay, you rightly highlighted that now things are changing in a tighter way. So people say that once our diabetic patient is, type 2 diabetic patient is there, he's already in a moderate risk rather than low risk. So once a patient is in moderate risk, he should be having a LDL of 70 and a non-HDL of 100. And by the chance, if he is having atherosclerotic cardiovascular disease, of course, we want LDL to be less than 55, and HDL again, just add the 30 milligram to that 55. Next. So the study background of this paper was that it was in people with diabetes. Statins were the basis of primary and secondary prevention of cardiovascular disease by reducing LDL cholesterol, but evidence is lacking on the comparative effectiveness of statin on non-high density lipoprotein cholesterol. So non-HDL is thought to be a more strongly associated with the risk of cardiovascular disease than LDL statin in our LDL in statin users. So if the patient is by chance using a statin, we have to look at non-HDL rather than HDL. So this table is telling us about the statin dosing. What is the recommendation of American College of Cardiology, American Heart Association, European Society of Cardiology, and NIH and NICE guidelines. So they classify the intensity of this statin therapy according to the reduction in low density lipoprotein or low density cholesterol. So here we can see that patients are given these 7 types of statin, but in Indian context, we can say that we are more or less using atorvastatin or simvastatin or rosuvastatin. In fact, we are most of the time using these 2 statin, atorva and rosuva. So if you look at atorva, you find that moderate intensity LDL reduction is something like 31 to 39. As I told that in diabetic patients, we don't give low intensity LDL lowering statin. So either moderate intensity or high intensity. So regarding atorvastatin, it is more than 40% reduction. Just go to the previous slide, please. We find that atorva 40 to 80 milligram is considered to be high intensity, and it is reducing by 40% of LDL. And similarly, if you look at rosuvastatin, you find that 5 to 10 milligram of rosuvastatin is considered to be moderate intensity. Our emphasis is more towards 10 milligram. And if you say high intensity, it should be between 20 to 40 milligram. Next. So here we find that if you look at the result of this study, which was a meta-analysis, performance on non-HDL cholesterol by statin intensity, we find that rosuvastatin at high and moderate intensity was effective in reducing the concentration of non-HDL cholesterol compared with placebo, and rosuvastatin at high intensity seemed to be the best performing statin in direct comparison with other statin intensities. So most of our patients require moderate or high intensity, and in that context, if our diabetic patient is having, let's say, other risk factors or having established atherosclerotic cardiovascular disease, he should be on high intensity statin therapy in the form of rosuvastatin 20 to 40 milligram or so. So result of this study was telling us just previous so the result performance of non-HDL cholesterol by statin intensity is telling us that rosuvastatin at high intensity seemed to be the best performing statin in direct comparison with other statin intensities. So whether you are looking at comparing rosuva to atorva or rosuva to simva, you find that rosuva considered to be the best. And if we are giving high intensity, it is definitely going to have better results. So moderate intensity, as we just discussed, it is lowering the LDL by 30 to 40%, and high intensity is lowering by some say 40, but most of the time we say it is 50% or more. So rosuvastatin at moderate intensity was ranked as the best statin treatment. Surface under the cumulative ranking curve was 77.5, and the second best treatment was rosuvastatin at high intensity. So our diabetic patient require non-HDLC to be looked at, and we either give moderate intensity and high intensity rosuvastatin to our diabetic patient. Next. And the important discussion point here is that data which is derived from large number of these patients, from more than 20,000 participated from the randomized clinical trial, shows that non-HDLC lowering effect at 12 weeks of this rosuvastatin gives a moderate to high intensity doses, and simvastatin and atorvastatin at high intensity doses were the best performing statin at lower level of non-HDLC compared with the placebo over an average of 12 weeks of period treatment. And in low to medium risk of major cardiovascular events and possible primary prevention, rosuvastatin at moderate and high intensity doses and atorvastatin and simvastatin at high intensity doses were the most effective statin. Rosuvastatin was the most effective in reducing the level of LDL cholesterol to a tune of something like 72 milligram per deciliter, similar to our estimates for a high intensity doses. So dear friends, it is clear cut now that in our type 2 diabetic patients, we have to look at non-HDL because triglycerides are high, and most of the patients are having small dense LDL particles, and once we say that statin therapy is to be given, as most of our patients require statin therapy, it should be either moderate intensity or high intensity. So the conclusion of this study was that what this study added in our knowledge, this network meta-analysis indicated that rosuvastatin at moderate or high intensity doses was most effective at reducing level of non-HDLC in patients with type 2 diabetes. And these findings can guide decision making for clinicians and support policy guidelines for the management of lipid levels with non-HDL cholesterol as a primary target in our patients with diabetes. I think I should stop here, and over to you, Dr. Sanjeev.
Thank you, Dr. Sharma, for a nice presentation in brief and analysis of single paper. So, Aries team, Dr. Ajit Mehta has joined. Any feedback on that?
Yes, sir, still he have not joined. I think we
Okay.
just talked to him. We will be joining within 5-10 minutes. I don't know, but he's telling that he will join within 5 minutes. Till then, we can continue with the discussion part.
Okay.
Dr. Sharma, my points were 2 or 3.
Yeah, please.
One is assigning the risk to diabetic people. Long back in Steve Hafner put it, diabetes as MI risk equivalent.
Yeah.
Subsequently, it was shown not truly the real data. And again, it came back as diabetic as very, very high risk. So there must be certain profile of diabetic people, whether age of onset, duration of diabetes, or phenotype, or certain metabolic syndrome feature. Would you highlight which diabetics are truly a CV disease in development?
Absolutely. So it's a very important question, Dr. Sanjeev, that diabetic patients are not similar patients. They have so much of heterogeneity. Some patients are developing diabetes at a very young age. Some are developing at an elderly stage. Some are obese, some are lean, some are normal body weight. Some are having a strong family history of cardiovascular disease. Some are having strong, you can say, other comorbidities and risk factor for cardiovascular disease. So Steve Hafner highlighted that diabetes is a cardiovascular risk equivalent. Then it was refuted. And then we realized that a type 2 diabetic patient, after 10 years of diabetes, now he is having high glucose and he is also having hypertension. Dyslipidemia is, I think, is always there in our diabetic patient, because diabetic patients require lower LDL and non-HDL as compared to a non-diabetic because of small dense LDL particles. So that's why once the patient is having longer duration of diabetes, I think these patients require, or they change their category, and now we can consider that they are at a high risk of cardiovascular disease. Absolutely. Thank you.
Dr. Sharma, the newer risk factor like air pollution is emerging. Ethnicity of Indian, another. Third is the lifestyle factors for Indians, the kind of food they eat, and a lack of physical activity in high stress individuals are not taken into account in risk scoring.
Absolutely.
Probably many experts believe that ethnicity should be assigned an additional risk points. So what is your observation on this?
Absolutely. Because we Indians are different from other ethnic group. And even if our BMI is not high, we all carry a abdominal obesity. So that is another important point, that we are having highly metabolic abdominal obesity. Our risk of developing non-alcoholic fatty liver disease is very high. And once a patient is diabetic and he's by the chance obese also, then there is a 70 to 80% chance of non-alcoholic fatty liver disease. And he's again, NAFLD is again a risk factor for cardiovascular disease. So in all this scenario, where you are having so much of stress, so much of pollution, so much of, you can say, lifestyle stresses, and people are not sleeping properly, and everybody is running after, and there is so much of day-to-day stress in our life, that also makes us more prone for the development of these lifestyle diseases and cardiovascular diseases. You are absolutely right. You are muted, I think. Yeah.
Insulin resistance underlying in a diabetes
Yeah.
is one which drives atherosclerosis from pre-diabetes onwards. And there are no clear-cut tests for most of the physicians across that there is insulin resistance.
Absolutely.
So how do people can think of insulin resistance playing a role in a given patient?
So there are two answers to it. Once we say type 2 diabetes, it is already having insulin resistance. But we can always look at the markers. For example, acanthosis nigricans, skin tags, abdominal obesity, or double chin. These are clinical markers that patient is having insulin resistance. And of course, we can always measure HOMA-IR, which is a very simple way of looking at fasting insulin and fasting plasma glucose, and you can multiply it, and there is you can say subdivide it by 22.5 if you are measuring glucose in millimole, and 405 if you are measuring the glucose in milligram. So it's a very simple way of calculating. But otherwise, we all know that if a patient is having high triglyceride, that is another triglyceride index, what we say, is another measure of insulin resistance. So high triglyceride is an indirect measure of insulin resistance in our population.
Past
Yes, sir,
history
Dr.
of
Ajit Mehta
PCO
has joined, sir. Dr. Ajit Mehta has joined.
past history of GDM and PCOD.
Yeah, PCOD again, the pathophysiology behind PCOD is again very important. That is, it is a insulin resistant state, and those patients who are developing GDM, there are two things there. Because of pregnancy, there is increase in insulin resistance, and beta cell dysfunction is not able to cope up with the amount of insulin required during the gestation. So these patients are developing gestational diabetes. After delivery, many of them revert back to a normal glucose tolerance, but 50% or more are again liable, or you can say will develop type 2 diabetes in the next 10 years or so. So these patients are also having high insulin resistance. With
So
yeah,
there will always be some marker in majority which would indicate that there is an insulin resistance underlying as part of etiopathology.
absolutely, absolutely.
Dr. Ajit Mehta, we welcome you in the Krivast Academy meeting. I would request you to kindly unmute yourself so that you can take part in the discussion. Dr. Mehta.
Hello.
Yeah, Dr. Mehta. Dr. Sharma just presented
Hello.
one paper
All of you.
which was on non-HDL in diabetic people. And rosuvastatin turned out to be really good. So, Dr. Sharma and Dr. Mehta, both of you, do you think between atorvastatin versus rosuvastatin, a change in HDL component with a statin could also contribute that HDL going up? Do you have any kind of a literature experience, personal experience of effect of a statin on HDL component? Because we don't have a dedicated HDL therapy. Dr. Mehta, you are still mute. Yes, doctor.
If you compare different statin and HDL, high density cholesterol, then there are some signals that rosuvastatin do cause some improvement in HDL. But probably this improvement is a bit very small improvement. So we can't say that to increase HDL, we have to give rosuvastatin. But of course, rosuvastatin is more potent in reducing LDL as well as non-HDL, and additional benefit may be like we are having improvement in HDL.
So by sheer percentage lowering of LDL by rosuvastatin will also have an impact on a non-HDL component of which was evaluated in your paper.
Yeah, absolutely.
Dr. Mehta, would you be able to talk from there? I can show the slide, or you are sharing the.
Yeah, could you please share the slides, because I'm still in the travel, and then I just stop the car on the side, and then I don't mind presenting the slides. I'm sorry for the inconvenience.
So I will straight go to your slides.
Yes. Yes.
I welcome Dr. Ajit Mehta, who is a senior interventional cardiologist based at Pune. He is a consultant at Jahangir Hospital, Apollo Hospital in Pune. Has published 15 articles in reputed journal. Many awards, had been an icon of health by Times, has frequently been on television in patient education program, doctor education program. So Dr. Mehta is our third expert today, and he's going to talk on optimal statin therapy, a vital strategy for major adverse cardiovascular events reduction. So over to you, Dr. Mehta. We just had Dr. Mehta a talk in relation to one Scotland paper and one on non-HDL in diabetic people by endocrinologist Dr. Sharma from Jaipur.
Okay. So a very good evening to all of you, and thank you very much for the introduction. And sorry, I couldn't attend the entire meeting because I was in a travel, just finished my cases. The efficacy of intensive lipid lowering therapy on the reduction of LDL cholesterol and major cardiovascular events. Can we have the next slide? Yeah, so the background is statins are the cornerstone of the lipid lowering therapy for reduction of the LDL's cholesterol. We all know that a significant proportion of the patients, especially those at high or very high cardiovascular risk, may need or would eventually be benefit from a high or moderately high dose of statin or combination of the lipid lowering therapy. Uh, the objective is the aim of the current meta-analysis was to evaluate the efficacy of intensive lipid lowering therapy regime on major adverse cardiac event reduction and reduction in the mortality. The primary endpoint basically we performed an intention to treat meta-analysis of published data of phase 3 trials evaluating lipid lowering efficacy on major adverse cardiovascular events. And the primary endpoint was MACE reduction, which was reported from 11 trials, a combination of 11 trials where more than 135,000 patients were taken into account, and a secondary analysis of reduction of the myocardial infarction, stroke, and total mortality. Next slide, please. So if you see the result of all these trials, the meta-analysis of 11 trials where more than 115,000 patients were included, and the MACE, the major adverse cardiac events, were reported in about 12% of the patients who received intensive lipid lowering therapy, as opposed to 13.79, almost 14% of the patient who were in the control group. So there was almost 15% reduction in the incidence of MACE, and these were all the trials where the meta-analysis were considered for the reduction of the major adverse cardiac events. Can we have the next slide? So the meta regression analysis showed a linear correlation between absolute LDL reduction and the risk of MACE. VITR is to reduce major adverse cardiac events in the long term. So all these trials, all the trials are shown as the LDL-C cholesterol level goes on decreasing, the risk of major adverse cardiac events also goes on decreasing. Can you have the next slide? And the meta-analysis has showed the incidence of myocardial infarction was 17% less as compared to control group during therapy. Next slide. The incidence of stroke was also almost 19 to 20% less as compared to a control group in a lipid-lowering therapy arm. The incidence of myocardial infarction, the I'm sorry, the slide is not visible. The CV mortality, the result on CV mortality, lipid lowering therapy was associated with significantly lower CV death in all the trials which have been shown here. Can next slide? When we talk about lipid lowering therapy in or high lipid lower therapy agents, we always have one of the major concern is a safety concern with high statin dose. But if you see the serious adverse cardiac events was same that received in an intensive lowering therapy versus in control, 26.8 versus 26.7. So it was almost equal. There was no significant side effect in a control group vis-a-vis patient who received intensive or a high dose statin therapy. So the efficacy of intensive lipid lowering therapy for the reduction of the LDL-C and major cardiovascular events, more than 135,000 patients from 11 trials were considered in this meta-analysis. 7 trials were for intensive lipid lowering therapy, 4 trials for lipid lowering therapy combination, and there were more than 17,000 major cardiovascular events registered. So, the result of this meta-analysis was that intensive lipid lowering therapy for LDL cholesterol reduction supports equivocal efficacy of these therapies on major adverse cardiac events reduction, and importantly, adds on the efficacy of cardiovascular mortality. So, in conclusion, lipid lowering therapy for LDL cholesterol reduction significantly reduce the risk of MACE and CV mortality. Clinical trials with lipid lowering therapy endorse the key role of LDL cholesterol and cardiovascular disease and support that LDL cholesterol might be a primary target for treatment in patients with or at high risk for cardiovascular disease. Current evidence consistently supports the efficacy of available intensity lipid lowering therapy for LDL cholesterol reduction and on MACE and cardiovascular mortality reduction. Thank you.
So thank you, Dr. Mehta. Our today's first paper was about a huge number of patients hospitalized and then discharged with a cardiac disease. But only 80% of the patients were prescribed statin and 20% were not prescribed. Large number who needed high intensity were prescribed low or moderate intensity statin. So in your experience, in your interaction with other practicing physicians who refer, why people shy away from high intensity statin? What do you think? Even in genuine cases, we will come to diabetic and high risk factor who also qualify for high intensity. But true secondary prevention, ACS, MI, stroke, and whatnot.
So basically, probably when we treat this patient for acute coronary syndrome, angioplasty or bypass, we as a cardiologist we make sure that they try to reach the target LDL level whenever possible with the highest intensity dose of statin, rosuvastatin, atorvastatin. Sometimes you call them back after about 4 to 6 weeks if LDL is not under control, depending on the patient's risk profile. We add ezetimibe or probably bempedoic acid or probably after 4 weeks, as we have been giving PCSK9 inhibitor also to this patient. But once this patient go back to their physician, they always have a phobia or very anxiety about the side effect of the lipids. What the LDL level goes down less than 50 or 40, would they have a cognitive dysfunction? If you leave on them a high dose of statin for a long time, or would they have a myalgia? So these are the probably anxiety on a part of the physician who generally refers.
Dr. Sharma, in the past episode, we covered up one special session on side effects.
Yeah.
And statin associated muscle symptom called SAMS was one of the sessions. And in that session, we showed clear-cut data that irrespective of the dose of a statin selected, people would have a muscle symptom. We classified them, we correlated with CPK level and everything. Physicians perceive that 20% of patients would develop SAMS, but in the literature, in all kind of analysis, it's only 9%. So probably 10% develop, perceived is 20%.
Yeah.
So what is your interaction with people around? Why this statin dose gets reduced?
Yeah, absolutely. The physicians are having a fear of muscle symptoms and signs. In my practice, we can say that I have hardly seen any patient who is complaining of these muscle symptoms. Occasionally, we do encounter, but some of these patients has to be looked into whether they are having some other complaints regarding muscle. For example, hypothyroidism is an important endocrine disorder where we should first treat it and then give statin. So many times we see that patients are given statin therapy even in frank hypothyroidism. So that is a very important message, that first treat hypothyroidism with L-thyroxine sodium supplementation and then try to reduce LDL cholesterol also. Second,
vitamin D also?
Vitamin, yeah. So many times our patients are also having low vitamin D. So people are using vitamin D with calcium. Some are giving them weekly preparations for a period of 8 weeks or so, and then continuing it with every month or so. I don't think that is a bad practice. It is because we see that vitamin D deficiency is not uncommon in our population. So it should be given. And our usual practice is to give for 8 weeks 60,000 vitamin D units, and then every month 60,000. So that will cover that. Probably we are having sufficient amount of vitamin D. And the second, as I told you, is look at hypothyroidism. And then whether patient is really having statin intolerance, then we have to go for some testing, as you say, CPK, etc., creatine kinase, etc. We have to look at that. Thank you.
Dr. Mehta, you are there or you are not there? Probably
No,
not
sir,
there.
I think he has left. He has left.
He was anyway in the car.
Yeah.
Yeah, sir.
Because probably
Network issue.
Yeah.
Dr. Sharma, he presented a paper in relation to obviously the MACE events and 11 trials which were selected. In the previous discussion, once we had a topic in relation to target-oriented LDL target-oriented dosing versus 50% reduction, which is irrespective of a baseline.
Yeah.
So if you achieve 30%, you would reach, let's say, 80 milligram of LDL.
Yeah.
But if you try for 50%, you would reach 60 milligram LDL. And the studies showed that 60 had lower incidence of CV disease compared to 80 milligram.
Absolutely. Lower
So
the better.
50, lower the better, and 50% reduction was the goal.
Yeah. And our Lipid Association of India is again highlighting beautifully that you divide your patient into moderate risk, high risk, very high risk, and extreme risk. And then accordingly, even they go up to a level of 35 milligram. So as our cardiologist friend was telling us that physicians are afraid of lower LDL. So I usually tell our patient that at the time of your birth, your LDL was 35 or so. So a newly born baby was having a LDL of 35. So he was absolutely healthy. So till 35, there is not going to be any problem in your body. Your anabolic, your androgens and all other steroid hormones will be normal, and there will not be any cognitive disorders or Alzheimer's, etc., which is feared by many of our physician colleagues.
In one of the previous sessions, we discussed and showed a paper that giving a statin was associated with a lower incidence of Alzheimer's disease instead of a higher. We also discussed that half-life of cholesterol is 5 years, and the brain produces its own cholesterol when LDL is low. So one does not have to worry when a serum or a blood LDL level has gone too low. So all those side effects have been discussed in previous episode, and we would come back with again some of those papers, but we try to screen a newer and newer papers which have been published, and that's how we picked up these 3 papers for today's discussion. Thank you, Sharma, for joining.
I think today's message was absolutely clear that we should give a statin to large number of our patients. It should be according to the intensity, moderate or high, depending upon the risk factors and calculating their cardiovascular risk. Beautifully conducted, Dr. Sanjeev. Thank you.
But Dr. Sharma, one of the constraints many people in the past have explained that it was the cost, because 40 milligram cost almost 54 rupees with some of the brands. But as patient care initiative at Eris, they have kept a flat price of 17 rupees for all 10, 20, 40 available at the same price. So that patient can surely take 20, 40 without extra cost.
Absolutely. This is a good
remark. Your final words, and we can close the session.
So I will just say Dr. Sanjeev has moderated the session beautifully. Clear-cut messages were given to our colleagues, and we should be looking at statin therapy more towards providing benefit to our patients and reducing significantly MACE outcome, major adverse cardiovascular events, rather than causing some side effects, which is not very common, which is very, very rare, I should say. And intensity of the statin therapy should be there. And there, I think the Eris is providing benefit to our patients. Thank you very much.
Thank you, Dr. Sharma. Over to you, Eris team.
Yes, sir. So thank you very much, Dr. Sharma sir, for your very nice deliberation of this very interesting topic on statins. And also thank you very much, Sanjeev sir, for nicely moderating the session. So total we have completed 7 sessions of this Crevast Academy, and we will also continue such session with new interesting topics related to statins in future as well. So thank you, sir, and have a very good night.
Good night. Thank you. Good night, Dr. Sanjeev.